Hello, I'm Stephen Patterson, Executive Director of MedVR, a 501c3 nonprofit. We have a global audience today, including most of the EU countries, Brazil, Peru, South America, Malaysia, Hong Kong, and India. So welcome to the MedVR talk series. We host regular talks by medical XR experts, thought leaders, and innovators that tell the story of the medical XR innovators' journey. We have over 40 recorded talks on our website as a community educational resource. In partnership with some of Boston's leading hospitals, we work to create the missing part of the medical XR R&D pipeline, an interdisciplinary network of clinical experts and immersive technology experts, while we simultaneously build the MedVR accelerator. Before we get into today's talk, I'd like to talk just for a moment about our January 10th talk, New VR Diagnostic Options in Neuro-Ophthalmology, Brain Disorders, presented by Matthias Aberg, MD, PhD at the University of Zurich Hospital, and founder director of Machine MD. This is super interesting because it's using VR cameras and to actually measure visual responses that a neuro-ophthalmologist would usually measure manually. It'll be moderated by Shaunak Bashi, MD. He's a MedVR advisor and resident physician at USC Roski Eye Institute. Let's get started. There's just one housekeeping note. If you look at the bottom of your screens, there's two chats. One is marked Q&A. That's where you should put your questions. The other chat is for the audience. So look for the one marked QA when it comes to submitting questions. Let me introduce our moderator. Margot Paul is a clinical assistant professor in the Department of Psychiatry and Behavioral Science at Stanford School of Medicine. Dr. Paul began her VR work in 2017 after joining Dr. Kim Bullock's virtual reality immersive technology clinic and laboratory in the Department of Psychiatry and Behavioral Sciences at Stanford School of Medicine. Dr. Paul won the Cheryl Cooperman Dissertation of the Year Award for designing and implementing a feasibility study and three-arm pilot randomized controlled trial to examine the feasibility of using VR headsets as a way to administer behavioral activation therapy for participants with a diagnosis of major depression disorder. With that, I'd like to turn things over to Margot, and I'm looking forward to this talk.
Thank you so much, Steve, and thank you for having me. I'm honored to be here, and I'm honored to introduce our speaker today, Dr. Walter Greenleaf. He's a neuroscientist and a medical technology developer at Stanford. He worked for over 3 decades in the field of digital health systems with a focus on developing the use of VR technology for use in healthcare. He's an advisor to multiple Stanford programs. He's also the founding chief science officer for Therapeutics, a pioneering company in software as a medical device. He's currently advising Interaxon as chief science officer. In addition to his work at Stanford, he's the business, technology, and neuroscience advisor to several medical product companies, investment groups, and accelerator and incubator programs. And today, he's going to provide an overview of how VR, AI, and biosensing technologies are converging, and will elaborate on how this will impact behavioral medicine and mental health care. So we're very excited to have him here today and to hear his talk.
Well, thank you, Marco and Steve, and I am very excited to be here. It's a very exciting time for our field, and I'll try and give a bit of a brief overview of what's going on, and then also hopefully we may have some time left over for questions. And Margot, in particular, I'm excited about your very relevant work looking at behavioral activation and as a method to address a serious mental illness, major depressive disorder. I think it's a great example of how we can take this new technology, and sometime soon I'll probably stop. I hope we all stop saying it's new technology and it's just part of how we do things. But currently, VR technology is viewed as an emerging technology. It's starting to move away from the academic research centers and the early adopting groups, and is soon to be part of the standard of care, and already is. And I'll give some examples of that. But at this point, it's still new. And Margot, I think you should be commended on your work there.
Thank you so much. Yeah, I agree. I think for us and what we talk about at Stanford and the VR clinic, we just talk about how important it is to get this research out there, to get it disseminated so that clinicians feel comfortable to use it as a standard of care, or at least an adjunct type of therapy. And so that's what I definitely want to focus on coming up and coming, into the future. And we created a behavioral activation app, and we're hoping to get it out there and disseminate that, and have that as an impetus and catalyst for people to start to use VR in their standard of care and therapy.
Yeah. Well, let me jump in. I'll give a bit of an overview, and then let's hopefully return to this part of the conversation. There are so many things emerging right now that are coming together in a very supportive and confluent way. VR technology is emerging. We no longer just say VR. The terminology is still evolving. I think most people now are saying immersive systems or extended reality, because we no longer just have systems that block off the rest of the world. We have systems that mix the real world with the computer-generated world, or overlay it with video information. And I think with the term spatial computing, mixed reality, extended reality, augmented reality, we're still haven't yet come down to the final nomenclature, but that's part of how it goes. And the technology itself is starting to pick up speed in terms of adoption and lower price points. But what I'm particularly excited about is in our area of focus, looking at mental health, psychiatry and psychology, and behavioral health in general. We now have some new tools by being able to leverage the wearable sensor technology and machine learning, AI technology to interpret the information, generative AI to be able to rapidly develop new environments to use to evoke a cognitive state or an emotional state, and teach people skills to manage their emotional states. It's just converging in a really amazing way. So let me share my screen. I'll start to give my overview, and then stop, and then we can continue the dialogue. Okay. Is that coming through okay? Fantastic. Okay, well, here's the overview. Well, I'd like to start out by reminding everyone that we do need to pay attention that there's a looming healthcare crisis caused by an aging population. I became very conscious of this when I was working with Stanford Center on Longevity. Just to talk about the US, but this is really a worldwide problem. Our population has doubled since the 1970s, yet family sizes have gotten much smaller. This is creating a large demand on healthcare, and all we have to do is the math, and we know that these demands will become even more impactful with an aging population, with people living longer with neurodegenerative disease and other problems. It's going to become very expensive. We need to get ahead of it. And in particular, we need to take a look at those issues that are becoming even more prevalent post-pandemic, and also just with the way our culture is evolving. There's been a shift in demographics and lifestyle, putting more and more pressure on our healthcare system to address issues in the field of mental health. We can't do anything to address this demographic shift other than to leverage technology. We can't grow caregivers fast enough to make up for the difference. And until we come up with better ways of preventing some of these mental health issues from occurring in general, we need to come up with new ways of supporting and providing therapies that we know are effective. That's why I spend a lot of time working with some of the groups at Stanford that are involved in clinical uses of virtual reality technology, both on a research level, but also on an applied level. But I also, because we need to translate the work that's done in the academic arena out into the field, I also work with a number of healthcare networks, pharmaceutical companies, medical device companies, helping them bring in AR and VR technology to the next generation of healthcare. We're in the middle of a digital health revolution where the shift of where healthcare is provided has shifted to the clinic, although we still use clinics. But now the patient is the center of care, and care can be provided in many cases in the field to wherever the patient is located. And that's a good shift. It allows us to reach previously underserved populations. We also now are seeing a move from the analog to digital. What used to be handwritten records, we have great ways of capturing information from almost every medical device that we use. And we're entering the era of medical wearables, where there's a large amount of information related to our physical status that we can collect by the technology that we wear or the technology that we use. And we're also seeing change in our thinking about how digital technology can play a role in healthcare. We can now have combination therapy where we might have an app that goes along with a prescription medicine or with a medical device too. And this allows us to do some very powerful things. We're also seeing that now that the world, more than half the people have access to a digital health system, digital health platforms is becoming part of our therapeutic process. This allows us to collect a large amount of data, and with the evolution of some very powerful AI systems, we're able to, at a population level or a community level or for research, sift through this data and come up with better understandings of both trends and also what types of approaches can make a big difference in terms of helping support our population. And we can conduct research on this data and come up with better paradigms related to clinical care. And it's not just the physical aspects of our health that we're able to capture and put into this analytical system. We also can capture things related to our brain health or to our emotional state, and not just as individuals, but as families or as communities and groups. We see the evolution of passive data collected, for example, from cell phones of how fast someone is typing or what they're typing. If they opt in and allow access to that, we can come up with a brain health biomarker. We see voice analytics being used as a biomarker for anxiety and depression and pain. Facial expressions tell us a lot about emotional states, and we're getting better at capturing that, along with pupil dilation and eye gaze. And then we can evoke a cognitive state using technology like an AR tablet or a VR system to come up with ways to challenge and measure the response of an individual. So it's really exciting. So some of the emerging and confluent technologies that we're seeing is, well, of course, sensors are promulgating. We're seeing them being built into so many systems out there, and we can passively collect data that relates to behavior. We're seeing new systems that can collect data that otherwise we might have to do a blood draw to get. We collect from the surface of the skin and collect that information. Again, with the evolution of machine learning and predictive analytics, generative AI, we now have some new tools to evoke and measure and quantify and analyze the very rich data that we're able to get from these systems. We're also seeing a change in how digital health is delivered and how it's perceived. The tech titans are moving into healthcare, Apple and Google and Samsung. And it's really going to be pretty profound to see it shifting from just being healthcare networks, insurance carriers, medical device, pharmaceutical companies, government regulation agencies being the major players, now seeing other groups come in And with the speed that the technology companies move at developing and the emphasis on personalizing the experience and making with good design systems that are appealing to use, I think we'll see changes in our healthcare system occur over the next 5 to 10 years that will be quite profound. Our regulatory landscape is adapting, and we're starting to be more comfortable with leveraging telemedicine where appropriate. And nicely enough, we are shifting our attitudes about mental health care. The stigma seems to be dissipating, and we now have, as I'll mention, more tools to help provide more impactful healthcare in the mental health arena. One thing to keep in mind is the technology companies are now starting to focus on how to leverage technology to personalize the user experience. Instead of a one-size-fits-all interface, we'll have dynamic interfaces to information that is being used to make our use of technology more appropriate for our cognitive level. If we are alert, or if we're sleepy or perhaps not focused, the technology can adapt to us. And we're also looking at ways that we will allow our technology to help us interact in a more comfortable, easy to use manner with our buildings, with our refrigerators, with our transportation systems. So this emphasis on collecting information about the user that the tech companies are developing, we can leverage and are leveraging and applying it to mental health care. Again, the emphasis on personalizing the user interface is something that we can use to help improve our delivery of mental health care and personalize that delivery of health care. The field of affective computing has always focused on developing systems that interpret our emotional state and can adapt accordingly. This is something that there's been a lot of deep research for decades in. It's not an easy task, taking the signals that we can collect and interpreting them correctly to understand someone's emotional state. But we've had decades of very talented researchers looking into this area. And now finally, we have more tools to help them do their work and leverage what they're doing. I'm excited by the way we're seeing biomarkers that are related to cognitive state or emotional state being moved out into the healthcare system. One example is the company Ellipsis Health, which has a voice-based vital sign for mental health, anxiety, and depression. But there's other groups also working in this area and being brought into the clinical ecosystem. We're also seeing groups that are leveraging facial expressions and other signals, like such as EEG, to provide these to go hand in hand with our VR systems, so that we can both evoke a cognitive state by using a VR system, and then measure the individual's response to that evocative system. The other thing that's pretty cool is we're starting to see the concept of the digital twin paradigm that's been used previously by cities and by manufacturing systems that are expensive to maintain and to predict when a problem might occur, move over to our healthcare ecosystem, so that we now can come up with a model of us and bring in our genetic information, our metabolic information, our medical history, medical imaging, and then do some predictive modeling to understand what may impact us and help prevent that. And then when we do have a clinical problem, have a specific model about us where we can say, well, what if we tweak and change this parameter? So again, this change in concept will make a big difference. And one thing that I think is important to keep in mind is that this digital twin paradigm, although it can be used to leverage biosensing and all the other data that can come in to come up with a model of someone's healthcare system, we also can look at the impact of the community. We can look at the family, we can look at the work environment. And again, we need to be careful about protecting this information, but we can make sure that we build things that are not just based in isolation for the individual, but how they function in the community and their support network. This allows clinicians to come up with a very precise way of managing the patient. And we're starting to see this move forward in a robust way. One company that I'm excited about is Octave Biosystems. They take a precision patient management approach to multiple sclerosis. And I think as more and more groups move forward with coming up with the tools to go beyond just the clinic, but to look at the patient and look at all the factors impacting them, keep the clinician alert as to that, we're going to see some very amazing changes and improved functions. So, it's important for us to keep in mind our clinical infrastructure is already very overburdened. And as we move to an informatics-based profession, we need to design these systems so they don't create additional time burdens and certainly reduce the amount of paperwork we have to deal with. But well-designed tools will help us do that, allow a clinician to manage their patients in a more robust manner without creating more of a burden. So shifting gears now to see, well, what's going on in the immersive field specific to mental health. We're seeing a lot of things move forward. We've had more than 3 decades of opportunity to do the research and development. With the cost of VR and AR technology coming down, we're seeing things move beyond the research arena out into the clinical care arena. We have systems that have been validated, but with small numbers of patients in the trial, we need to go beyond that and extend that to more robust clinical validation. But we're seeing things move beyond just the early adopters and out into the field. So really the full stack of healthcare is being impacted by this, starting with training to improved assessments, improved interventions, new ways to facilitate adherence, ways to reach people in remote and underserved areas, and new ways to facilitate prevention and facilitate wellness. And of course, new ways to facilitate research so that we can keep a cycle going of improving these systems. So again, with technology, starting with the head on a display, but moving into other ways of collecting information, we're seeing new players into the arena coming from the tech sector. And I think this is going to give us new tools for clinical care. I think it's important to mention, though, that although people tend to think of the icon of VR is the headset, there's so much that goes beyond the headset that is part of the systems that are developed. The creation of the user experience, the analytics of that experience, the dynamic change of that experience based on the user's response. All that is very powerful, but we don't tend to see it. We tend to focus on the headset, and that is what we think of when we think of VR for clinical care, but so much going on behind the curtain. It's been exciting for me to see how the field has evolved. I got involved back in the late 1980s when systems were uncomfortable to wear and expensive, but we were able to do research and find out where the pathways were that were useful and where the blind alleys were. And many amazing colleagues have spent their careers focusing on bringing us to this point. And I mention this because many people think VR is such a new thing that we don't have a large amount of background literature, but we do. There's been a lot published, and it's worth going back and taking a look at it. If you haven't had a chance and you're interested in the field, it's worth looking back, because a lot of the problems that we're currently addressing now as we move the technology out have already been addressed in some basic studies. Again, we need to redo some of the studies with today's technology, but we've done a lot of work already laying the groundwork. What's exciting is the technology is evolving pretty fast too. We're having new ways of bringing new sensations into the VR experience with haptic feedback. We now have spatial olfactory systems where we can bring the sense of smell into the VR system in a 3-dimensional manner, where we can hold something close to us and smell the pizza, or turn around and walk across the virtual room and see where the garbage might be or the flowers might be. It's really quite amazing how this lab adds another layer of stimulus that can evoke memories and change the tone of an experience. We're also getting much better at our avatars. They don't have to look like robots, and they can capture our facial expressions, our mannerisms. Of course, there's a whole level of concern about not having our avatars escape and be used for purposes we wouldn't want them to be. But the fact is now VR doesn't have to be a lonely experience where you are interacting with a virtual environment on your own, or if other people are there, they look like robots. Now we can start having more robust experiences with avatars that look and sound much more realistic, should we choose to. Of course, we could look like a lobster if we choose to also. We're also seeing the evolution of, with cloud-based rendering and generative AI, very robust virtual world technology where we can meet other people and have experiences that are very believable. And that's, I think, giving us new tools to help address clinical problems. Last time I had a chance to do a bit of a survey, there were more than 427 emerging medical VR companies addressing almost all sectors of healthcare. So the momentum is growing. And we're also seeing in the US new ways to finance the use of this technology through better coding and ways for reimbursement. I'm excited by what our friends at the VR Healthcare Network are doing, the tremendous momentum there. These numbers are already old, but when I last had a chance to talk with the group of the immersive systems at the VA, they were rolling out VR at more than 160 clinical sites. They trained thousands of staff members to use it for more than 30 different clinical indications. So it's moving fast. So why is this? Well, clinical VR systems have more adherence and more engagement. We're able to facilitate better learning and memory by creating a better sense of presence and context for the user, by making our systems engaging and novel and fun. We can create more of an experience as opposed to what you might see by reading something or looking at something on a flat screen. This cognitive engagement is so important, especially in the field of mental health. And by having someone actively involved, we facilitate retention and memory. So there's a whole neuroscience of how VR and AR systems have impact and support clinical care. It's very nuanced, but the top level message is that because we can activate experiences that have all our senses involved and create a reward feedback loop, we can show people progress in their therapies, have them focused on what needs to be focused on, provide insights and perspective, and create experiences that have emotional impact. And this gives a clinician new tools to help the patient with their healthcare journey. And we're able to leverage the power of storytelling. Usually in a clinical experience, it's very hard to have the time to bring forward a narrative, but we can help people by leveraging technology and providing systems that people can use at home and not necessarily in the clinic. We can create an overarching context and make the healthcare experience more of a healthcare journey. And it's really amazing how we can leverage some of the tools and techniques that our colleagues in the gaming industry or the gambling industry have used to promote adherence and help people come back to be part of their therapeutic process. So, and this is so important because with mobile health, we've seen a lot of dropout rates. There's been some wonderful systems developed leveraging mobile health technology, but the adherence rates are unfortunately low. We haven't seen that with VR and AR systems, the much better adherence rates to this technology. And I believe it's because of what I mentioned before, that we're able to create more of a cognitive engagement and show people progress and give them the feedback they need to keep coming back to use the system. We can leverage our mirror neuron systems in the brain. For example, one of the projects at the Stanford Virtual Human Interaction Lab was to age progress an avatar of an individual, facilitate a dialogue with your future self so that you can see in real time how your choices you make about use of alcohol or nicotine or exercise or nutrition can impact you. A powerful way to help motivate people. So to give more of an overview of the impact in mental health care, we see, starting at the training area, ways to come up with simulations of the patient experience, to have standardized patient simulation, to teach people how to handle a difficult situation, to have a critical conversation, to deliver bad news in an empathetic way, and to also learn how to learn from our patients what we need to learn to help them with their healthcare journey. We can teach skills using VR. Of course, these can be surgical skills, but it can also be skills that a mental health professional needs to have to work with a patient. We're coming up with a tremendous new amount of objective assessments relevant to mental health care. We can, of course, collect physical movement for physical therapy, occupational therapy, but we can do neuropsychological assessments and new ways of applying the technology to behavioral medicine. And we don't always have to be wearing a head-mount display. We can create an interactive experience to do a cognitive assessment using a room environment, for example. I'm excited by some of the things that are going on in terms of assessments of cognitive function, executive function. One company I recently had a chance to take a look at their work is ViewMind. They do a complete assessment of all the executive functions using a VR headset, focusing on looking at pupil dilation and eye gaze and challenging people's cognitive system, using that as a platform where they can standardize the amount of light that's going into the eye and come up with some very robust measurements that are rapid. There's no learning effect, and they come up with a detailed assessment very precisely for all the executive functions of our brain. I'm also impressed by groups like NeoAvra that are challenging our social emotional systems using VR and doing a very robust assessment of our responses. So what we do need to know is to come up with new standardized environments. We now have some tools to evoke and measure a person's response to a VR experience. As we want to promulgate clinical care and research, we need to come up with a better library of culturally appropriate, age-appropriate, diverse environments that we can use as a foundation for research and clinical care. I'm impressed by what our colleague Lee Williams is doing at the Stanford Center for Precision Mental Health and Wellness by combining information captured from wearable sensors, from imaging, from metabolic and genetic data, and using VR as an evocative environment to help come up with the different biotyping for looking at anxiety and depression and other mental health issues. I think this is going to be really important. We need to not treat everyone with a particular diagnosis with the same clinical pathway, but be able to identify the different subtypes and send people down the right clinical pathway. And VR and AR technology will be an important part of this. I'm excited by what we're seeing with groups like Altoida using a tablet to evoke a memory or a cognitive process and do a psychomotor index that correlates very strongly and helps identify patients that are converting from mild cognitive impairment over to neurodegenerative disease. So I've been talking mostly about the assessments, but now moving into some of the interventions. We see great work being used for preoperative planning and image-guided surgery in that field. But if we move into physical therapy and into mental health care, we're also seeing some really amazing things. I was impressed by the work of Adam Ghazali's group at the Neuroscape lab up in UCSF, where they've used video game paradigms to challenge the cognitive processes and evoke a response related to age-related cognitive decline. And being able to reverse for people in their 60s who've had the standard decline in some aspects of executive function, but by using the engagement of a dynamic VR system, reverse that score. And when they look back years later to see if the changes in that aspect of executive function had persisted after the VR engendered experience, even 6 years later, they see that some of the reversal of the decline had persisted. That's really exciting. There's groups starting like virtually focusing on neurocognitive evaluations and therapies. And as we move into mental health care, we know how acute the need is. We've had a backlog that we've been trying to reach to for years. People make that difficult phone call saying they need help with an addiction or with an anxiety disorder. And they're often told, well, your appointment will be months from now. We can do better, and technology is allowing us pathways to do better. And nicely enough, it's the full stack of issues in mental health care where we've seen VR and AR technology applied, ranging from anxiety disorders, addictions, depression, we've already talked about, chronic pain, autism, attention deficit disorder, psychosis, anger management issues. It's really been remarkable to see so many aspects of mental health care where new therapeutic interventions are being developed that leverage the improved cognitive assessments, but also leverage ways of reaching the patient and helping the patient through exposure therapy, for example. A lot of work using VR as a way to mitigate both acute and chronic pain. A lot of work going back decades, looking at post-traumatic stress disorder, phobias, and other anxiety disorders using exposure therapy. And then using VR as a way to help evoke a craving in an individual and teaching them the situational confidence or the refusal skills to help manage their cravings. It's wonderful now that with the use of generative AI, we can come up with evocative environments specific to the user's experience so that we can help them manage peer pressure, et cetera, and learn to manage their cravings and understand their own processes behind the problems that they're trying to address. And for us, we can also help with providing new systems to support preventive medicine and health and wellness. Some great systems are out there that support reducing stress and reducing anxiety on a non-clinical level, with individuals can download and use on their own. Issues teaching people better skills for weight management, for example. So what are the constraints? What are the gating steps to adoption? Well, I think it's really important that we appreciate that with these profound new ways of measuring emotional states and reactivity and evaluating our cognitive state, we also have some risks. I'm very impressed by the work of Nida Farhani, who has published the book, The Battle for Your Brain, and talking about not only the power of these new technologies, but also the concerns that in her book, she details issues like the need for privacy protections. Because if we're getting better at evaluating someone's response to a stimulus or their current emotional state, especially if we can do that with technologies such as webcams or voice analytics, although these are powerful tools in the mental health field, these can also be used for companies to try and understand what to sell to us, or worst case scenario in an environment where a dissident might need to be identified and punished for their thoughts. Or another example might be evaluating someone based on their online gaming behavior and the voice tones and reactivity and situational confidence and planning, and using that to make decisions about their career opportunities on the employment level without their consent or understanding that this information that they're putting out there just because of their online behavior can be used to discriminate about their employment pathways. So we need to get ahead of this and pay attention to the not just the power of this technology to help us do better healthcare, but also the concerns and how to protect the data that we're collecting. There's a lot of research gaps that we need to address. We have a lot of underlying research, but it's been with small sample sizes and with technology that, because it evolves so rapidly, that needs to be redone with today's technology. And we're also dealing with the perception that VR is some sort of science fiction-y gaming experience and not appropriate for clinical care. far from it. It's a powerful tool for clinical care, but because of its evolution, it's viewed as something that's not quite a serious technology by many. We also have an interoperability issue. There's many powerful systems that run on VR platforms now, but they don't necessarily use the same data system backend, the same user interface at the front end, and they're not necessarily positioned to work on if you have a comorbid condition, you're trying to address depression and chronic pain and maybe a mobility disorder. You might not be able to put them all on the same headset. And again, the data doesn't easily support comparisons across groups. So that's something that we're grappling with. And there's solutions on the horizon, but there's a lot more work to be done to get there. And then I think one of the biggest challenges we have right now is that despite the good design skills that many of the groups that are developing this next generation of technology have, they're often focused on the technology, the measurements, the reporting, but they're not looking as deep as they should at the constraints of our healthcare ecosystem. It's one thing to come up with a profound technology that can help our patients, but if we don't understand its impact on the current ecology of the healthcare ecosystem, if the technology requires another person to be hired to manage the batteries for charging, for example, or if creates an extra time or paperwork burden on the clinician, no matter how profound it is in terms of helping patients, it's going to be unacceptable to move into the healthcare ecosystem. So we need to do a better job of understanding how to best move new technologies into the healthcare system while reducing the burden on the healthcare system instead of increasing it. Nicely enough, I mentioned at the beginning of the talk how I'm very concerned about the looming problem of an aging population and the impact on cognitive aging on our seniors. Many of the things that are being developed will address this issue. And that's wonderful. But I'm also very concerned what we don't want to do is a job of design that we overburden ourselves with too many sensors we need to use, too many gadgets that we need to wear or sign into. We don't want to have a future where we're over-measured in a burdensome way that isn't useful, and as I mentioned earlier, might be problematic in terms of protecting the data. So we have to do a good job of design there. So in summary, things are amazing. The technology has been evolving for more than 3 decades, and it's finally at a point where it's crossing over into clinical care in a robust way. There's the full spectrum of healthcare is being impacted, and in particular with new tools for measurement and therapies and mental health care, we finally are able to move forward in a way that scales more easily and is more precise and, for the individual. And the momentum is growing. And we have some challenges, but it's exciting. And I think we'll see things move forward in a pretty rapid way. For those of you who are interested in learning more, there are 2 conferences specific, well, there's more, but there's 2 major conferences specific to VR and healthcare. One is organized by IVRA, the International Virtual Reality Health Association. Their next meeting is late February, early March in Florida. And then the Virtual Medicine Conference is in late March in Los Angeles. Both are amazing groups if you are interested in learning more. And thank you. And Margot, I hope we have a chance to continue our dialogue and maybe take a few questions from the audience.
Yes, thank you so much, Walter. What an amazing and comprehensive talk explaining how technology is constantly evolving and is used to treat many different mental health and healthcare problems. And I know a few questions came up for me, and so I would like to take the time to ask you and pick your brain, given that you are an expert in this field. And I also see that some people have other questions coming into the Q&A. So rather than raise your hand, please write any questions in the Q of A, and hopefully we'll get to that. So for me, the main thing that came up is just in seeing your presentation, you've shared the many ways technology is evolving to help improve lives and augment medical care. And something that I frequently get as a clinician who uses VR is from people that have been influenced by apocalyptic movies and movies where AI and technology is taking over the world. And I know you briefly addressed this in terms of talking about safety and privacy and security. And I know HIPAA compliance is definitely something that I consider as a clinician. But I'm wondering what you would say to those people who inquire about the potential downsides of just technology being so ubiquitous, and thinking of those movies and those warnings that technology is taking over the world and people aren't going to be interacting with each other as much. What would you say to those people, and what do you suggest to help mitigate that risk?
That's such an important question. And again, I guess I should apologize for needing to be so superficial about the whole topic, but hopefully I gave a bit of a broader brushstroke, and we can go into details a little bit more now. Well, we are asked about the singularity. We're asked about what will happen as AI moves out. Will jobs be eliminated? Will our privacy be compromised? Will our future be attenuated by the downside of these technologies? And I think this is our time to address this issue, and we must get ahead of it. And there are a lot of groups working on this, the XR Safety Initiative, for example, and other groups. I do think can be trade-offs, that when we look at a healthcare issue and put it to a patient, that we need to collect some information from you. We will keep it confidential, but there's always a risk that somewhere along the line, the information could escape. But are you still interested in opting in to let us collect this information? Here is the benefit for you. So I think we need to do a better job of identifying the trade-offs, identifying the risks, and making sure that patients are comfortable with the trade-off, the benefit versus the risk. I think we can do a better job of that. I think with blockchain and other ways of securing data, I think there's ways that we can both give patients agency over their data, maybe give them a click charge of some financial return when their data is aggregated and used as part of a federated learning system, for example. They should get some upside from that. I think the tools are there. The policies need to be put into place. I think it should be possible to provide very profound security for these issues, but we need to put in the rules for doing that. And we've seen in Germany, for example, with GDPR and some of their restrictions, it can slow down sometimes the advancements of the technology, but that's inappropriate if it gives us a better future and better comfort for our patients. It's on us to make sure as we evolve this technology, we do it in a way that respects confidentiality and privacies and gives patients agency over the use of their data.
Yeah, I totally agree. And as you were speaking, I was just thinking of the translation from actually having a chart to then EMR, and very similar concerns that people had of like, oh, I don't want my data online and just available for people to look at it and view it, and all the policies that have come into place around EMR and giving patients more autonomy and the ability to actually view their records. And I think that could be important when translating this into XR technologies as well, thinking about those same considerations.
In a related vein, we need to be careful that as we collect data for the powerful things we can do in healthcare, that we just don't do it from the people who are going to major medical centers. And we need to we are striving to make a conscious effort to reach underserved populations is the term, but people who don't go to major medical centers, we need to both reach them, but also make sure the data we collect as we build systems that are doing better diagnostics and better therapeutics, that it's comprehensive in terms of cultural diversity, age diversity, and personal choice diversity. That's also important. It's not just protecting the data, but also as we collect the data, make sure that it's as it feeds into our systems for decision making, that it is appropriately diverse.
Yeah, and that dovetails into a question that I had, and I see that someone else has a very similar question as well. So in order to avoid just collecting the data from these major medical centers, thinking about something I've encountered, and I see this person, I'm sorry, I can't pronounce your name, Gors Wichter, also said, is being in the clinical field and a clinical psychologist, I've encountered clinician hesitation to use these emerging technologies outside of these larger medical centers, people that are private practice clinicians and maybe do work in more rural areas. There's a huge preference for just what would be considered the traditional face-to-face therapy. And I know that you had shared that there's a plethora of background literature showing that they are evidence-based treatments. But what would you say could be the best way to help translate this research and what's going on and the research that I'm doing to these more rural clinicians and clinicians that work in areas that are seeing underserved populations and aren't in these larger medical centers?
Well, I think there's two ways that we can do that. One is, again, I'm very impressed what the U.S. Veterans Health Administration is doing in terms of moving technology out and not presenting it as this exotic new technology, but just how they can address some major problems and bringing it out to, people who otherwise, the VA healthcare system often functions as a safety net healthcare system. And it does go into remote and rural areas. It's not constrained by the coding requirements that other healthcare networks are often constrained by in terms of reimbursement pathways. So I think the answer, Margot, is we need to show the data. I think if we talk about the power of these technologies, but we don't show the data, we're just expressing an opinion. So we need to have facts that show here's the value of the technology, here's the facts behind its impact, and just really show everyone its value, and then give examples of where it's made a difference. And the examples are there. So we just need them to bring it to the attention of these clinicians who are still learning about the power, and provide it to them in a way that it's not a barrier for them to adopt it. Again, we have an overburdened healthcare system. So if learning to use this new technology is burdensome, it's really a matter of putting good design in place, I think, and good design for the patient's use, but also good design for the clinician's use.
Yeah, absolutely. And I think that that's happening with these emerging technologies, and also with talks such as this, and as you said, in IVRA and the VMed talks, just to disseminate the data and to let people know that there's actually data behind what we're saying, and that we're not just expressing these opinions. Okay, so I do have, because we only have about 7 minutes, I do want to get to some questions here. Danny said, in terms of length of time, is there any data that suggests a minimum, optimum, or maximum length of time for a VR experience?
Another question that is very important, but also hard to answer in a few minutes. But there is an issue. There's a couple issues. One is there's a vestibular ocular disconnect when we use the VR systems. We basically fool our brain and our visual system by placing screens close to the eye about distance. And there may be a concern for younger users that if they spend too much time and they have a developing visual system, that there could be some downstream effects. I think that by limiting the amount of time that we have people spend in our systems, and we can do a lot in just 20 minutes. So I think that is one concern, is to understand and do some research on what is the safe amount of time. But I think also as we have more augmented reality systems where you're not fully blocking out the built environment, you're interacting with it and using it, I think we'll start seeing systems that don't have quite that concern. But by and large, most of the VR clinical systems don't have the patient in the systems for very long. We should also acknowledge that the systems aren't designed to fit the smaller face of our youngsters, as well as maybe not, we need to understand the impact of the use of, and in terms of the technology as an impact on our culture, I think the VR technology is reversing a downward spiral in terms of the application technology. I think when we started texting and typing and focusing on Cartesian coordinates and flat screens, we narrowed the view of our world and we stripped away the robust communication we have with facial expressions and gestures. And by Zoom, where we have the always looking at someone's head instead of looking around the room. So I think this level of technology will reverse some of the adverse effects of an over-technologized world. And I think it may hopefully just fade in the background. We're back to 3D.
Yeah, and I think that it's really important to also just address too the idea that people I know that something people ask me is, with these kids and these youngsters, how is this any different than just gaming and becoming addicted to like gaming technologies? And as a clinician, I get that too from patients that I say, like, okay, like, let's use this for depression to incorporate pleasant activities. People say, well, how is this any different than like watching Netflix or watching TV? And with youngsters, something to consider too is just, I know when these gaming technologies first came out, the addiction concern to gaming and the fact that their brains are still developing and focusing on a screen and not interacting with other people. And I think that personally, that's why AR can be so helpful, as you said. But I would also love to know your thoughts on that as well. And for those people that are concerned in using these technologies for these youngsters, and how is it very different than, gaming and just using video games, for example?
Well, it's different than gaming in that it's designed to have a purpose, and we can design some of the guardrails that are necessary to make sure it's curated and safe. We also can make sure that if we do a good job of design, that the impact is the cost trade-off of leveraging technology to provide benefit is there. And it can open up the world for people. Often people who are socially isolated, we can help them reach out to other people, learn this. If they have trouble with social skills, we can exaggerate facial expressions and body language and reinforce understanding the emotional state of others, using that to help with feeling comfortable, do role playing in a safe way. People often will say things to avatars that they may not say to someone in real life. So it's a powerful tool. We have to design how best to use it. But I think we can mitigate some of the issues of the layers of technology have created by opening up the pathways and then teaching people how to identify where problems are and how best to identify it. It's such a complex issue. I wish I had more time to go into.
I know. And I want to be cognizant of time and the hard stop at 10. So I would like to invite Steve back, but thank you so much, Walter. This was really enlightening, and I really enjoyed picking your brain on your expertise and vast knowledge. And I know I personally feel like I could just continue this conversation for several more hours, but unfortunately we don't have the time. But thank you so much.
Well, let's follow up and keep our dialogue going, Marco. And
Yes,
Steve,
absolutely.
thanks so much for giving me the opportunity to talk to this group.
Yeah, it's a pleasure to have you back, Walter. Thank you so much. It's nice to have a projection, a roadmap of where we're going with these technologies that's concise and well considered. I think this will be some good curriculum on our website when it's up and available. It should be available in a couple of days. So if you want to go back and listen to what's been discussed, please go ahead. Margot, thank you again for joining us and moderating it. I can't tell you how much better the talks are that when we have moderators that are domain experts like yourself. So thank you. I know you've got a patient right now, so I'm going to thank you. I'm going to thank our audience for coming. And please go to our website, register, and take a look at the talk coming up on January 10th. I think it's going to be really, really unique, and the ability to measure, to really diagnose people's conditions with VR is a new capability. So thank you, and we'll see you next time. Take care.
Thank you so much.
Bye-bye.